So good evening, everyone. I wanted to welcome you all to this year's Nebraska Oncology Society Evening Speaker Series. Now, pre-COVID, the Nebraska Oncology Society would meet pretty regularly to discuss different topics in oncology. However, this year, we have been able and been kind of forced to pivot to a virtual setting until we are able to meet in person again. And so for our fourth topic this year, we have gynecological oncology. And here's our agenda for tonight's event. And I also want to thank this evening's exhibitors and encourage everyone to visit their booths on the virtual platform. Now, with this format, I just wanted to go over a few housekeeping items. First is we are using Zoom. You can find all of your webinar controls by hovering over the lower section of the Zoom screen. You'll be able to find your microphone, your webcam, and chat box options, among other things. Please make sure that you keep your microphones muted throughout the meeting. If you need to ask questions, please use the chat box or wait until the Q&A session at the end of the presentation to unmute yourself and ask your question. We'll address all questions at the end of the presentation. You can also use the chat function to send messages privately to individual attendees. If you have technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to send me a message via email, and I'll be happy to try to help you. The presentations are being recorded and will be uploaded to our event website. We encourage the use of webcams if you're able to in order to help have a more face-to-face atmosphere to the meeting. I also wanted to remind you to use our virtual platform and visit our exhibitor booths. You can chat with company representatives live, so make sure to take advantage of that opportunity and thank them for their participation. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing patient care through oncology research, education, and healthcare legislation. We also encourage you to participate in tonight's competition. Each exhibitor has a unique competition code located somewhere in their virtual booth. If you are able to find 5 of these codes and email them to me before the end of the day, you will be in the running to win a $100 gift card. One CME credit is available for this event. So feel free to complete the evaluation on our event homepage to get your certificate. And without further ado, I want to now introduce our speaker, Dr. Kathleen Moore. Dr. Moore is currently an associate professor in the Division of Gynecological Oncology at the University of Oklahoma. She is also the Associate Director for Clinical Research and the Director for Phase 1 Drug Development Unit at the Stephenson Cancer Center at the University of Oklahoma. She received her MD from the University of Washington School of Medicine in 2000, and she completed her residency in obstetrics and gynecology at McGee Women's Hospital in Pittsburgh, Pennsylvania in 2004. There she went on to complete her fellowship in gynecological oncology at the University of Oklahoma in 2007. She has since been on faculty at the University of Oklahoma. Nationally, she serves as the NRG Chair for Ovarian Cancer, Associate Director for GOG Partners, and has participated in many NCI-sponsored clinical trial initiatives. Additionally, she has authored over 200 manuscripts and has led Phase 1 through 3 trials, including those with registration intent. Thank you for joining us today, Dr. Moore.
Well, thank you. Can you hear me okay?
Yes.
All right, I'm gonna go ahead and share my screen and share screen 2, share. And showing up okay?
Yes, Dr. Moore.
All right. Fantastic. Let's get started. It's really my honor to have been asked to speak to you all this evening, and I appreciate everybody showing up at the end of what's probably been a long day. But I do have, I think, a pretty, I have a lot to pack in 60 minutes because there's a lot going on in ovarian cancer. There's a lot to be proud of and a lot to be excited about in terms of therapeutic options for our patients. As was stated, I do entirely drug development. That's actually my entire job. And so I work with big and small pharmaceutical companies and do a lot of consulting and clinical trials work, which is all listed here for you to see. And what I'm going to really talk about is just very briefly, because I think this audience knows the status of kind of a historical standard of care, but really talk about what's changed really radically in the last, well, since 19, so just really barely 2 years, and then what's coming both in frontline and the recurrent setting for women with ovarian cancer. And so for those of you that have been doing this at least as long as I have or a little bit longer, you'll remember, I remember being a fellow, and if you had advanced ovarian cancer, you got surgery. We tried it, and maybe we got it all out and maybe we didn't. And then we gave paclitaxel and carboplatin. And then we watched, and that was really the standard of care. And I'll show you what that accomplishes in a moment. But the world has dramatically changed, and this is a really nice review article for those of you that like high quality review articles. This is one of them. It just came out, and it really shows really how complex frontline planning has become and how much we're trying to individualize to patients. And so there's a lot more consideration of comorbidities. There's actually clinical trials that I don't have time to go into that have looked at the impact of age and frailty. There is an increased and appropriate emphasis on doing primary cytoreduction among women who have a high pretest probability of achieving no gross residual and getting them to high volume surgeons who can accomplish this. Otherwise, they are best served by neoadjuvant chemotherapy. I believe that's been well established, and that's the timing of surgery. We think about these cancers differently. Again, those of you that have been doing this as long as I have, remember the slew of phase 3 trials, some with thousands of women. If you just had ovary cancer, you came on. Didn't matter if it was mucinous or clear cell or endometrioid or low grade, or maybe you had a borderline, they all came on. And so no wonder we didn't really make any headway, because we understand now these are different diseases. And high-grade serous and high-grade endometrioid really have to be studied, at least with current assets, as a particular entity. Stage, of course, is important. And then of kind of biggest import is genomic profile, and we're going to go into that in some detail. Certainly the importance of BRCA as in terms of how it impacts familial counseling cannot be understated or forgotten. We can create previvors by identifying women with BRCA-associated cancers, offering testing to their family members, and risk-reducing surgery until we can do something better. Will prevent 20%. We do that 100% of the time. We prevent 20% of new ovarian cancers in the world. So that should be what we strive for right now. And we're going to talk about the predictive capability of BRCA diagnosis in terms of response to PARP inhibitors, as well as homologous recombination deficiency as a new assay. So we'll go into those. But really, I think just to start with like the lay of the land, ovarian cancer, this is sort of SEER data that goes up through 2017. I actually think this is going to look different after PARPs. This is pre-PARP approvals. 2014, we had it for late line therapy, but pre-frontline PARP approvals. And you can see the incidence kind of inexplicably, maybe because of better testing, we can't really explain this, is going down. Mortality is going down. And combination of those plus, I think, better therapies means since 2013, we've had a 40% increase in the prevalence of women living with ovarian cancer in the developed world. This is US data. If you look at European data, it mirrors this. It's very consistent. And so as much as we'd like to say we're curing more women, at least as of this timeline, we're probably not. But what we are doing is a better job in frontline individualization, as I just talked to you about. And we have a lot better therapies for recurrence. And so incrementally, each improvement in progression-free survival equals a longer cumulative overall survival for women. So that's good news until we can prevent this dread disease. So this is a little bit of good news that we should be proud of. I tell my patients this, but it really speaks to the need. There are a lot of women living longer with ovarian cancer. So we need effective therapies for them. We need to cure it in the front line. And then when they recur, we need more effective therapies for them, which we're doing right now. So I mentioned to you kind of the olden days, which was paclitaxel and carboplatin. And so this is kind of what you can expect with paclitaxel and carboplatin alone, which is pretty good. Let's just be honest. This is ICON 8. And I show you ICON 8 not to talk about ICON 8 too much, other than to say it's the last clinical trial I think we'll ever see in frontline ovarian cancer that's just paclitaxel and carboplatin with no molecular profiling and no maintenance. This is it. And this was a study of paclitaxel and carboplatin given 3 different ways. And clearly there's no difference. And so you can use every 21 days and feel pretty good about that. But the thing to point out here is that this progression-free survival curve on the left looks essentially identical to every progression-free survival curve we've done since we've had paclitaxel and carboplatin, in that if you look at, I don't know if you can see my cursor, but if you look at the upper left, you see this 20% of women who progress within 6 months of completing chemotherapy. So this group of women, despite the exquisite chemosensitivity of chemo-naive ovarian cancer, for whatever reason, 20% of these tumors will come back within 6 months. This is primary platinum-resistant disease, and it's just a bad actor. And this is one area where we have not really cracked the egg of how to do better. We're starting to figure it out, but preventing this is a big deal if we could prevent this, because these women have a median overall survival of about a year. Acquired platinum resistance is a very different thing. Primary platinum resistance, this is something we have to present, 20%. And then by about 3 years, despite your best efforts, with paclitaxel and carboplatin alone, 80% of women will have recurred. And then they enter this many years, fortunately, but unfortunately, many-year kind of hamster wheel cycle of repetitive cycles of chemotherapy until ultimately this disease claims their life. And so we have to do better. And so we started doing better with bevacizumab, and this is old data, not quite as old as paclitaxel and carboplatin, but old. This came out in 2011, so it's a decade old. Incorporation of bevacizumab with and to follow chemotherapy. These were the 2 key studies, both positive. Primary endpoint was progression-free survival, and with about a year of maintenance, decreased the hazard of progression by 20 to 30%, which is pretty good. Not a home run. If you like a sports analogy, it's a base hit. Was widely adopted in many parts of Europe, was not approved in the United States till 2018, but many of us used it anyway. Because it's a modest improvement, but it's there. It shifted the curve a little bit to the right. And so this is something to be proud of. The day these were presented, people started asking the question, well, did we stop the bevacizumab too soon? If we kept it going forever, would you have seen an overall survival advantage? Would the progression-free survival have been better? Maybe we stopped too soon. And why they said that, it's not just speculative. They looked at every study that had been done with bevacizumab, and you can see when you stop the bevacizumab, the curves come back together. And we call this the banana sign. So they make a banana. So you stop the bev, the curves come back together. So if you don't stop the bev, maybe they stay apart forever. And that led to the AGO Boost study, which started like the day after those studies were presented in 2011, like literally started a few months later. And it asked the question, we're going to give 15 cycles of bevacizumab, or we're going to give 30. And we're going to look at progression-free and overall survival. And this was just presented at ASCO this year, took a decade. These studies take a long time. And we were all very excited about this in the GYN oncology world, because usually when things take a long time to recur, these patients are doing really well and the experimental arm's probably working. But in this case, it was not different at all. Not even a smidgen better. So here's progression-free survival, and in the interest of time, I'm just showing you one of the slides, but they broke it out by every clinical risk factor, high and low, stage 4, suboptimal, blah, blah, all the things. No difference in progression-free survival, and then not surprisingly, no difference in overall survival. And this was really one of those things there were a lot of early adopters for this who believe, you call them Bev believers, and I like bevacizumab. It's a great drug for our patients. And in high-risk patients, you had patients on 56, 60 cycles of bevacizumab in the front line. These people really believed in this banana effect, which is why we do clinical trials, because there's no hint that it's better. And so the early adopters need to stop. It just leads to more toxicity, and we just have to do better in other ways. But this was a very, very important negative study, and the AGO should be congratulated on getting it to completion. So that's the bevacizumab story. The really big story, of course, is PARP inhibitors. And since 2014, basically every new approval in ovarian cancer has been a PARP inhibitor, with the exception of the 2 bevacizumab approvals during this time period. On the top, you see EMA approvals, and on the bottom, you see the FDA approvals that largely mirror one another. So we can go through this. We started, of course, with SOLO-1, and I had the great privilege of leading this study. It's like the highlight of my career. And I'll remind you, this is also an old study, started in 2013. And we enrolled women who had BRCA-associated cancers, had undergone and attempted a surgery, either interval or primary, and were in complete or partial response to their platinum-based chemo. That wasn't dictated by the study. They came on the study at the end. It was a switch maintenance. And they were randomized to olaparib twice daily or placebo, which was the standard of care. This was pre-bevacizumab. And we continued this until toxicity or progression, or 2 years. And the 2 years was kind of arbitrarily picked because the FDA told us we couldn't continue it forever, which is actually what we wanted to do, which would have been wrong. So we picked 2 years because it was sort of 2 standard deviations beyond what the control group was estimated to be. So a little science and a little arbitrary, but we had to pick a stop date. And the primary endpoint was progression-free survival. And so you can look here, and hopefully you can see the light blue is a little light, is the placebo, and the maroon is olaparib. And there's a couple of things I like to point out. This just shows you up to the 2-year cut point. And so the curves here are just dramatically different. You know, in ovary cancer, and probably I know there's a lot of you that are medical oncologists, probably not a lot of tumors, maybe melanoma and like immune therapy showed this, or BRAF inhibitors for like this degree of separation. Like we'd never seen anything like this. But you can notice on the left, there's no more primary platinum resistant disease. You still see it in the placebo arm though. 20%, these are BRCA-associated cancers. The myth about them was they were all cured with chemo alone, and they didn't need this maintenance. We're over-treating them. Wrong. 20% of them are still platinum resistant in the first line. Very surprising. We had never studied them. Now we know. You don't see any. It's 4% with olaparib. So we've eliminated that, which is important. And then by the 2-year mark, we have 35% of patients who were randomized to placebo remaining disease-free, and as compared to 74% who were randomized to olaparib. And then if you follow this out, of course, this takes you out to the updated analysis. When we presented this in 18, we had 41 months of follow-up. Susanna Banerjee from the Royal Marsden presented at ESMO last year, 60 months of follow-up, which is what I'm showing you here. So we have almost 50% of women remaining disease-free at 5 years, as compared to only 21% in placebo. Now, some of those women are cured, right? There is a group who are cured. We just don't know who they are. And so we're going to over-treat some percentage in order to help the rest until we can figure out who doesn't need anything. We still have a few more years to follow for overall survival, probably 2023. But the addition of olaparib for 2 years reduced the hazard of progression or death by 70%. And the reason I said we would have been wrong by continuing the olaparib, because you might say, well, if you continued it, no one would have progressed. But actually, after 2 years, and it probably happens around the 18-month mark, the event rate in the olaparib group and the control group become the same. And so once in these Kaplan-Meier curves, when the event rates become the same, the efficacy of kind of the experimental arm is the same as placebo. So it's not really, you don't think it's efficacious anymore. And we don't really see any difference beyond 2 years. And we can look at this in every other study as well. And so this prolonged use, at least in this population, now that may differ in other populations, but in SOLO-1, you know, we had 44% of patients who were stage 3, not stage 4, primary cytoreduction to no gross residual and BRCA. So the best prognostic group of high-risk advanced ovarian cancer you could ever have in a trial that had never been studied before. And so we had a lot of patients coming on in complete responses, still with high-risk disease. There's no such thing as low-risk advanced stage ovary cancer, but lower high risk. In that group of patients, probably 2 years is enough. I think in other groups of patients, we have to still figure that out. And I'm going to talk about that next. But SOLO 1 was paradigm and practice changing, as it should have been, and led to global approvals, and is the standard of care. PARP inhibitor is the standard of care to offer women with BRCA-associated cancers, either germline or somatic. There is no alternative. Now, if they choose something different, knowing everything, of course, there's always shared decision-making, but its PARP inhibitor is the standard of care, unless contraindicated because of the degree of benefit. So I'll just say that out loud. So that was just in BRCA-associated cancers. So then the kind of rest of the world, so well, what about us? What about the rest of the patients? That's only 25% if you include somatic, who were included in SOLO 1. Maybe we would benefit from a PARP inhibitor. And so there were 2 studies that looked at that, PRIMA and PAOLA. So I'm going to show you PRIMA first. PRIMA is niraparib, and PRIMA enrolled women kind of the same as SOLO 1. You had to have advanced high-grade serous or endometrioid cancer, have responded to your frontline platinum-based chemotherapy, and an attempted surgery, either interval or primary. And they were randomized 2-to-1 to niraparib or placebo, initially for 3 years, but it was amended later to be indefinite use. Now, the difference here is it was all comers, not just BRCA, and it was stratified by homologous recombination deficiency as determined by the Myriad assay with a score of 42 or higher. So it's one of the 2 FDA-approved tests. And so the primary endpoint is progression-free survival in homologous recombination deficient tumors and intention to treat. Those are the 2 primary endpoints. Now, PRIMA purposefully enrolled a very different population than SOLO or PAOLA, which I haven't told you about yet. So it's important to remember when you're looking at survival curves, because these are going to look very different. But this population is probably one of the highest risk populations we've ever studied. Almost 70% of them were dispositioned to neoadjuvant chemotherapy. 35% had stage 4, which is about 5% more than SOLO. And 31% had a partial response, and many came on with measurable disease. They couldn't have greater than 2 centimeters, but they had measurable disease. And so this is quite a clinically high risk population, and clinical factors matter in terms of prognosis. So that's just important to remember. But here are the primary endpoints. Here's the overall population where you have an almost 40% reduction as compared to placebo with using niraparib, 40% reduction in the hazard of progression or death as compared to placebo. And then in the homologous recombination deficient population, which includes BRCA by definition, they were included in this population. That was about 30% of the whole group. So a substantial portion here, we got almost a 60% reduction in hazard of progression or death. And so these are the primary endpoints, and both very positive. And so the study met its endpoint. Now, they did look at the subgroups a little more granularly. These are not hypothesis tested endpoints, so that's why they don't have p-values, but we do pay attention to them. On the left, you see just the BRCA associated cancers with a hazard ratio of 0.4, so 60% reduction in the hazard of progression or death. In the middle is a group that I'm particularly interested in, and I'll come back to them on a slide in a few. That's this BRCA wild type, but homologous recombination deficient. This is about 20% of our patients, and they benefit dramatically from PARP. Here, the hazard ratio is 0.5. And then surprisingly on the right, you see this group that's determined to be homologous recombination proficient by this test. And the test isn't perfect, it's pretty good, where you wouldn't expect PARPs to work. But you did see a hazard ratio of 0.68, so a 32% reduction in the hazard of progression or death. That's what we see with bevacizumab, and we think that's a pretty good drug. And so because there was really no evidence of lack of benefit, the FDA approved niraparib for all comers. Now, and doesn't require a companion diagnostic. You can do, of course, HRD, and a lot of us do, to counsel patients about the magnitude of benefit and help them with shared decision-making, but you don't have to have that. You can just say, I'm going to use niraparib, and that's completely fine based on the data. And so this came out in 2020. So it's just been out just over a year. So relatively recent, but a very important advancement. Now, We talked about bevacizumab at the beginning. I like bevacizumab, especially in patients at stage 4 or neoadjuvant, higher risk patients. I like using bevacizumab. But if you start bevacizumab and then you determine someone has a BRCA-associated cancer or now HRD, and you want to use a PARP and you'd already started Bev, you would have had to stop the Bev to go to the PARP, which makes no sense because you haven't used Bev in the way that it's supposed to work. So that made a lot of us uncomfortable, especially in Europe, where in many countries, the only place you can use Bev is frontline. And so they were like, we're not using Bev. So we're going to do a study and we're going to add PARP to it and prove that we can do it so that we can do what we want to do, basically. So this was an investigator-initiated trial that Isabelle Ray-Picard designed and became an FDA registration study, which doesn't normally happen, but here it did. So this is PAOLA-1, and it's just what I said. Advanced stage patients, all comers who received bevacizumab for at least part of their regimen and were in a response, were then randomized to continue the bevacizumab alone with a placebo, or have bevacizumab plus 2 years of olaparib. And they're stratified by BRCA, and the primary endpoint was all comers. So it wasn't even a biomarker-directed endpoint. Remember, it was an investigator-initiated study. So here's the primary analysis, which is olaparib Bev versus Bev. So this is versus an active control, not a placebo. You see a hazard ratio of 0.59, so 41% reduction in the hazard of progression or death by adding olaparib to Bev. That's pretty solid. We were all very excited about this and really thought it was going to be an all-comer indication. They also did these subset analyses, not hypothesis tested. Again, there's no p-values here. And you see on the left, the BRCA-associated cancers with a hazard ratio of 0.33. In the middle, this really interesting group of BRCA wild type but HRD with a hazard ratio of 0.43, so almost a 60% reduction in the hazard of progression over Bev alone. And then interestingly, in this group that's homologous recombination proficient, and they used the same assay as PRIMA, they used the myriad with the same cut point, there was no benefit over Bev. So olaparib Bev over Bev did not have a benefit. And so even though this wasn't hypothesis generating, in the US, the FDA said, well, you can use this, but only in patients who are homologous recombination deficient, of course, including BRCA, but not homologous recombination proficient, which is 40 to 50% of our patients. Now, other countries like Brazil did not follow suit, and they can use it whenever they want, and other countries are still making decisions. This is a very new indication, but in the US, we are limited to this. And so these are the three main studies. I'm not going to talk about VLIA because veliparib's not being, unfortunately, pursued for any regulatory path right now. And so kind of one of the interesting things that came out of this is if you think about the biomarkers and BRCA, you can think about, well, okay, Solo with switch maintenance has a hazard ratio of 0.3. And Paula with bevacizumab and olaparib has a hazard ratio of 0.33. So a lot of people looked at that and said, well, the hazard ratios no better, and so we don't need bevacizumab. You just need olaparib. And you can't say that because the hazard ratio just reflects the reduction in the risk of the hazard of whatever you're looking at, here progression-free survival, in that study. You can't compare hazard ratios study to study. So all you can say is that both of these studies show an unprecedented improvement as compared to their control, which is placebo for Solo and Bev for Paula. But this still is a question because you want to know what's the best way to treat your patient who's sitting in front of you and you've identified her as cycle 2, her testing has come back, and maybe you haven't started Bev at that point. I don't start it by that point. And I find out she has a BRCA-associated cancer. Does she need Bev? What's the best way to treat her so she has the best chance of cure? And we don't really know, I just have to tell you. And the reason we don't know is because Paula, and I'm not being critical because it was not designed as a registration trial, it was kind of converted into one. Had it been designed as a registration trial, it would have had another arm, which was olaparib alone, but it doesn't have that arm. And so we don't know the answer. But what we did is we tried to figure it out. And so this is a study that Ignace Vergote led, where because Solo and Paula are both AstraZeneca studies, we had access to all the individual patient data. And so we took all the patients on Paula, and I'm referencing the figure on the right here. Took all the patients from Paula who had BRCA, associated cancers. And then we looked at patients on solo who got olaparib, who clinically looked like Paula patients. So we did this propensity weighted matching to basically recreate the third arm of Paula of olaparib alone from the solo patients. So it's a mathematical exercise. And then we redid the Kaplan-Meier curves. And so what you can see is that exploratory study. In green is Paula, in orange is the matched patients from solo, and the hazard ratio is 0.71. So there is a bump, but the bump looks additive. And so until the study is redone, which honestly, I don't think it'll ever be redone, so this is probably what we're gonna have, I think what it allows you to do, or at least what I do with this, is it allows me to dissociate my decisions for Bev and PARP. Because if they're not synergistic, I don't have to use both. So if I'm going to use Bev, I start Bev, and then I send my testing. And if it comes back with a BRCA or an HRD, I'll talk about that in a minute, then I layer on olaparib. And you could probably layer on niraparib too, because there's safety data for that combination. If they don't, if they're homologous recombination proficient, I just keep the Bev going. If I haven't started Bev, which I don't use it all the time, and I discover someone has a BRCA associated cancer, then I feel really good about just using switch monotherapy because they're additive. And so I can kind of dissociate the decisions or separate decision points. The decision for Bev is early. The decision for PARP is once you get the molecular testing back, which sometimes takes a while depending on if you send tumor or germline first. And so that's, I think, what this allows you to feel comfortable about, that not every patient needs both. I actually believe that. And you can individualize to the clinical features that your patient presents with. Now, for patients who are BRCA wild type, but HRD, this is the study that needs to be done. I'm really trying to convince AstraZeneca to do it. Sorry. We can't do this fancy analysis between Prima and Paula. Number one, because they're two different drug companies, and so we don't have the individual patient data. And number two, sometimes you'll see us like overlay survival curves and try to approximate things, but there's such different patient populations clinically that I wouldn't even do that. It would be completely unfair. So we just don't have that data. And so for now, I think that we have to do the same thing, is dissociate the decision for Bev and PARP in this population as well. Although I will tell you, I am suspicious that there's synergy here. And the reason for that, some of you may recall, and I didn't put the slides in here in the interest of time, but in the platinum sensitive setting, Joyce Liu has looked at olaparib and cediranib, which is a VEGF TKI, and Mansur Mirza from the Netherlands has looked at niraparib and Bev in the platinum sensitive setting. And then they looked at outcomes, PARP alone versus PARP combination in BRCA wild type and BRCA. And then the BRCA patients, they got a little additive bump from whichever anti-angiogenic was added, kind of like we saw here. It was just a little bump, wasn't synergistic. But in the BRCA wild type platinum sensitive patients, who are largely going to be your homologous recombination deficient patients, this was pre that assay, you did see synergy with the anti-angiogenic drug in the PARP. And that's reinforced, of course, by the preclinical data. So I'm curious as to whether there's synergy here, because that would really change my behavior in this population. And I probably would use a lot more bevacizumab. And a lot of us are really trying to convince AZ to run that study to prove it. But for now, we still have to dissociate the information for these patients. HRP is really where we need to work. Niraparib does benefit these patients. I think bevacizumab is also good. Which one is better? Who knows? You do not know. I don't know. So if I've started Bev, I'm going to use Bev. If I didn't start Bev, I'm going to talk about niraparib. That's how I pick. We all have our own kind of way of looking at this, but the truth is we got to figure out why these tumors are proficient. Like, what's wrong with them? Are they CCNE1 amplified? Yes, a lot of them are. MYC, what's going on? And then address that rather than just trying to use the same drugs. And so that's what we're trying to do now. We had a lot of hope that immunotherapy would work in this group. and it didn't. It didn't. Sorry. So we have two studies that I'm going to go through quickly because they're both negative, unfortunately. One's Javelin 100, which incorporated avelumab with paclitaxel and carboplatin. And the other was my study, which was Imagine 50, which added atezolizumab to bevacizumab. There's so much data for this combination in other tumors that we thought it would translate into ovarian cancer as well. So these are both frontline studies. And here's just sort of the high level primary analysis for Javelin 100. They actually stopped this early because the group of women who were randomized to avelumab, chemo followed by avelumab, so switch maintenance, that's the gold curve, it did worse. It looked like they were trending worse than nothing. So that's always a concern when we see that. And then Imagine 50, which was atezolizumab and bevacizumab versus bevacizumab alone. Bev alone is in blue and the combo's in red. Fortunately, we weren't worse, but we were statistically insignificantly better. It was like a 2.3 month bump in PFS. Now, and then OS, both of these are immature, but no real difference. And again, I know that a lot of you are medical oncologists and there's a lot of interest in the tail, especially in lung cancer studies, and this sense that maybe we don't follow patients long enough to really see the difference, the differences in the tail. And that is probably true in tumors that have some inherent response to immunotherapy, which ovarian cancer really does not, at least not immune checkpoint inhibitors. So as much as I'd like to be optimistic that these curves are going to look real different in a few years, I don't think that that's true. And then if you look at the subgroups, like maybe it's not all comers, but maybe it's PD-L1, again, the lung cancer story, no benefit here. In fact, the avelumab looked a little worse in that gold bar. And then we had like a 3.6 month bump in the PD-L1 population for Imagine 50. Now, when we looked at this group of patients, and this is very exploratory, 20% of the population who had immune cell positivity greater than 5%, we hit the hazard ratio that we powered for the whole study, which was 0.64. But this is completely uncontrolled for other important covariates. And the truth of the matter is that at least in ovary cancer, we have never, ever, ever validated a positive exploratory endpoint when it's been tested in a prospective way. So the likelihood that this is real is unfortunately very small. Now, the other thing is that early on, like in 2015, there was really beautiful preclinical data presented in a lot of tumor models, but especially ovary, that said, well, the patients that have BRCA-associated cancers, these tumors have trouble fixing their DNA, and so they're going to have a lot more neoantigens, and they're going to be the ones that benefit the most from immune checkpoint inhibitors. And so both of these studies looked at the subgroup of patients who had BRCA-associated cancers, which admittedly was small, because these studies were running while all the PARP studies were running. So patients are smart, and they were gravitating towards the PARP studies. But there were, a fair number of patients on both of these, and there was zero signal that these patients benefited at all from immune checkpoint inhibitors. And so really a little bit back to the drawing board from that standpoint in ovary cancer. And there were early adopters here as well. I mean, I see patients referred to my phase 1 unit who were getting pembrolizumab because they were PD-L1 positive ovary cancer. And there's just no data for that or rationale given the phase 3 data that we have here. So what's pending now in the front line that we'll start to see results from probably late 2022 are these studies, with the exception of the Athena study, which is not highlighted. All of these are some combination of PARP plus IO with or without bevacizumab in all comers. Of course, the rationale being that you activate the STING pathway with this PARP IO combination, and so that may lead to some synergy. Unfortunately, that's not really been demonstrated overwhelmingly in the platinum resistant space, but they're banking on it in the front line. So we'll see. There's a lot of patients, 4,000 patients, patient lives that were on these studies. So we'll see if any of them are positive. Athena is a little bit different in that it's a true switch maintenance studies comparing PARP versus PARP IO. We may hear this one next year. So these are all completed accrual and maturing. And before we launch another IO containing drug, we probably ought to see kind of what happens here. So that's the front line. Now that we're using all these good agents in the front line, which is the right thing to do, what happens here? What happens in the recurrent setting? Well, we have to start all over figuring this out. So that's the truth. Here's all the, like if you're sensitive to platinum, meaning you haven't recurred within 6 months of your last platinum, and the longer the better. These are the kind of big studies. I didn't include the bevacizumab, that'd be another study. These are all still relevant. You know, all of these combinations would still be the standard of care for women with recurrent platinum-sensitive ovarian cancer. The question is what to use as a maintenance, because we know if we don't use any maintenance, that our median progression-free survival is about 5.5 months following a response to any one of these platinum doublets. So it's remarkably short. So maintenance really does have a strong role in the platinum-sensitive recurrent setting, but if we've already used bevacizumab and PARP inhibitors in the frontline, what do we do here? We certainly know we can use Bev again. We have lots of data for that. So that's on the table. But the question is, can we use PARP again? And a lot of us are. Have I done that? Yep. But no data. So OREO is not a super sexy study, but it's really important that it's looking at women who had a PARP in whatever line of therapy for maintenance, not for treatment, and then recurred with platinum-sensitive recurrence, responded to that platinum, and then they were randomized to placebo or olaparib. And it's, as you can see, there's two cohorts. There's a BRCA and non-BRCA cohort. And this is being presented next Friday. This Friday at ESMO. So this is highly anticipated to see what this shows. This is going to give us some new benchmarks, and I'll show you why that's important in a moment. So this is a really critical study for us in terms of how we take care of patients in this line of therapy. Now, we know, since we're using PARP so much now, that we're causing PARP resistance, just like everything else. There's so many ways. This is another fantastic review article that I would, if you want to learn, it's just so good. That kind of talks about the different mechanisms. And one of the mechanisms that we acquire PARP resistance is through basically restoration of homologous recombination proficiency. And it's so complex. But one of the more interesting ways is amongst patients who have a BRCA-associated cancer, or they've lost their BRCA protein due to methylation, methylation events, and they get demethylated. More on that probably in another talk. But you get these reversion mutations that we're increasingly identifying that basically restore the reading frame. And so someone that had and they still have a germline BRCA-associated cancer in the tumor, the BRCA protein's normal. And so they're no longer sensitive to PARP and in many cases to platinum. And so this was first shown, this is Liz Swisher's work from rucaparib, where it was a monotherapy rucaparib study in patients who had BRCA-associated cancers. And basically what it shows is, if you look at the bottom waterfall, and I know it's small, but the bars with the little stars on the top are all the patients with reversion mutations that were found in actually ctDNA. So they weren't even biopsies, they were blood tests that were gonna be able to identify this. And they didn't benefit at all from PARP. And in fact, in Aerial 4, which just was presented but not published, as compared to chemo, rucaparib versus chemo, for patients with BRCA-associated cancers who had a reversion mutation, they did better on chemo than they did on the PARP because the PARP just completely failed. And so identifying these reversion mutations is going to, and they're not even identified in OREO, right? So this is something that we're going to have to know up front. Like I want to know this up front if I'm considering using monotherapy PARP. Probably doesn't apply yet to combos, although we don't know, because I wouldn't use a PARP. And if I was designing a trial, I'd want to know who these patients were because I would at least stratify for them, if not have that be an exclusion criteria, because they're not going to benefit from monotherapy PARP. And so overcoming this, can you do it? Maybe. So again, this is another fantastic paper. It's so dense, you're gonna have to read it 3 times. But it's just fascinating going through, it's not just a reversion mutation, there's many. And the mechanisms by which the mutations are repaired may dictate, well, the mechanisms by which they're repaired seem to be associated with what caused the reversion mutation, either its exposure to platinums or its exposure to PARP inhibitor, or both. And so you see different mechanisms of repair based on what the exposures were. So you see DNA PK being very important, as well as these microhomology end joining pathways. And the MMEJ is one of the key pathways that looks like it's basically repairing these mutations. And the exciting thing about that discovery is that we may be able to overcome that with pol theta inhibitors. Pol theta inhibitors have just entered the clinic. Artios has one. And there's others. Jeff Shapiro at Dana-Farber, who's probably one of the smartest people on the planet, is also working with one. So how we use these, we don't know yet. You know, do you use them with a PARP from the beginning? Do you add them in when the CA125 starts to come up? Are they combination for after resistance forms? We don't know yet. You know, we're just getting these into the clinic, but we actually may be able to target this mechanism by which a lot of the reversion mutations form. And that's particularly exciting. So more to come on that. These are just entering the clinic, so we have a little bit of time before we really see kind of what these can do. Now, the other thing we've all heard a lot about are these combinations, like you have upregulation of VEGF or EGFR or MET or even androgen receptors that restore homologous recombination proficiency. And so if we kind of dual target those with a PARP inhibitor, we can overcome those mechanisms. There's been a lot of those strategies, the main one being targeting VEGF. With a lot of, again, beautiful preclinical work that like Tim Yap and MD Anderson and Stephanie LaRue, I'm showing you here, have done. So the point of this is really just to show you, like, we thought we were really smart, but we don't really know what we're doing yet. So this is Stephanie LaRue's work, where she enrolled women who had progressed on a PARP in their last line of therapy, not exposed, but progressed on the PARP. They graciously agreed to a biopsy. And then they went on PARP plus cediranib. So this anti-angiogenic PARP combination hypothesis. And it really didn't work. It didn't see a lot of responses, and they weren't long-lived. But the key thing about this is what she found in the biopsies. And so, so a lot of reversion mutations. 5 patients had reversion mutations in BRCA, 1 in RAD51B. You saw overexpression of RAD51C. And that's important because preclinical evidence shows that RAD51C deficient cancers are very sensitive to PARP inhibitors. And so loss of RAD51C promoter hypermethylation may lead to PARP resistance. So it's interesting here that we're seeing more RAD51C on these post-PARP samples, suggesting that they may have lost their promoter hypermethylation. We'll have to figure that out. The other really interesting thing here that I'll come back to in a second is that she found a lot of CCNE1 amplification. 33% of BRCA mutated tumors had an amplification. Now, these are mutually exclusive at baseline. So if you look at your baseline archival tissue, you will not find a CCNE1 amp and a BRCA. They're mutually exclusive. So these tumors are acquiring amplification with selective pressure, probably from whatever therapies. And that's likely leading to some of their resistance, but also provides us with an opportunity, another Achilles heel in targeting replication stress, which I'll mention in a moment. So this is the type of work that needs to be done to figure this out. It's so complicated. It's so much more complicated than I think any of us thought, that really trying to individualize these combinations for patients without liquid biopsies, which we're getting to, may be hard. You can't just biopsy every tumor in every patient. But this is how complex it is. Now, we do have some kind of things that we're excited about, just to show you what's in the clinic right now. Before I finish up, this is Panos Konstantinopoulos' work, and Gerber-Wolf as well at Dana-Farber, mainly arising from her breast cancer work, where she's discovered that if you inhibit PI3 kinase, which we all know lots of work in PI3 kinase. So there's nothing to do with having a PI3 kinase pathway activated tumor. It's just the inherent act of blocking PI3 kinase leads to suppression of BRCA1/2 expression and loss of homologous recombination proficiency. So it's like a metabolic intervention to induce loss of homologous recombination proficiency with this PI3 kinase blockade in certain tumors. Triple negative breast is where she first showed this. And then it was also demonstrated by Panos in ovary. So this is work that he did on the left, his phase 1/2 work with olaparib and alpelisib, which is a PI3 kinase inhibitor in platinum-resistant BRCA wild-type tumors, where the expected response rate for anything is about 5 to 10%. And every patient here had some reduction in their tumor, which is pretty remarkable. Not all of them responded. Most of them green, all the green ones were responses, but everyone shrunk a little except for one patient. So this is a really nice signal. It was completely irrespective of a PI3 kinase mutation. And so this is being tested right now versus investigator's choice chemotherapy in a study called EPIC-O. This is ongoing, sponsored by Novartis. But excitingly, he has additional data that this sort of metabolic intervention and reduction of homologous recombination proficiency may be particularly effective in patients who are PARP resistant. And so this study is coming through NRG. It's approval on hold. And so we are rolling the protocols under development. So we're still a few months out on it, but it's the same thing. It's just a different PI3 kinase inhibitor here, copanlisib and olaparib versus investigator's choice chemotherapy in platinum-resistant, PARP-resistant ovarian cancer. So this will be an incredibly important study. It's based on beautiful science. And if you don't know Panos, he's also one of the smartest people to work with and super nice. So if you are an NRG site, look for this to open. Now I mentioned, so these sort of trying to restore homologous recombination deficiency, we may be able to do. I'm excited about Panos's work. We're all kind of switching, like we all kind of switch loyalties sometimes. And so we're all sort of getting a little more excited about targeting replication stress, because PARP is still important in replication stress. PARP maintains the replication fork. So even if I've lost PARP sensitivity and homologous recombination pathway actions, I still have PARP sensitivity on the replication fork side. And so if I inhibit PARP there and create synergy, synthetic lethality by blocking something in that replication fork, I may be able to get somewhere in some of these resistant tumors. And so we're looking at that right now in these with ATR inhibitors in WEE1. And these are really gaining traction. And so this is really beautiful work by Fiona Simpkins out of Penn, where she's shown that PARP, and as I mentioned, PARP is of course involved in repair of DNA breaks, but it's also involved in stabilizing the replication fork through these lagging Okazaki fragments, which honestly she taught me about. But on the right, what you see here are all patient xenograft models from PARP-resistant tumors. And she treats them with PARP or WEE1 or ATR or both, and then looks also at CCNE1 amplification, which does appear to be a biomarker. Now, as an amplification or copy number, we're still figuring that out. But the point is that the tumors respond beautifully to these combinations of ATR and PARP in xenografts. And then the first evidence of this in ovary was presented by Dr. Simpkins and Wethington at ASCO this year. This is platinum sensitive, but PARP resistant ovarian cancer, phase 1 of ATR olaparib with a response rate of 50%. Now, we don't have benchmarks here, right? We've never studied this group of patients with a progression-free survival of 7.5 months. Now, these patients are platinum sensitive and they're getting this 4 treatments. This is how long they go, median of 7.5 months. So it's a nice signal. So we're pretty excited about this. I think the kind of caveat is, here's the Fresnel data. So this is an exploratory analysis from SOLO 2, which was PARP and BRCA-associated cancers and the platinum-sensitive recurrence is a switch maintenance. It worked amazing. But then they looked at the patients once they recurred again, and they're all platinum-sensitive again. And so they all got platinum again. And the patients who got platinum again after PARP are in blue, and their median progression-free survival is 7 months. Now, this is post-platinum, so it's longer, right? If you count however much platinum they got. But it's a lot shorter than the patients who didn't get a PARP, which is 14 months. And so in order to be excited about this, we really need to know what our benchmark is in this post-PARP, PARP-resistant, not just post-PARP, but PARP-resistant population, and Oreo is going to show us that. So then we'll know how excited about this signal we are in moving this forward. The other, of course, is WEE1, olaparib and WEE1, and Shannon Weston from MD Anderson led the EFFORT trial, also presented at ASCO, and enrolled mostly platinum resistant, some platinum sensitive, but all PARP resistant. And then this is the responses in the BRCA associated cancer. I'm going to flip through this a little bit quickly in the interest of time, but it wasn't super exciting. 20% response rate, it's kind of meh. But in the BRCA wild type, 31%, number one, WEE1 alone, 31%, that's pretty high. Anything really is pretty high, but we've never seen that with WEE1 alone, but WEE1 olaparib was 40%. And the clinical benefit rate was 70 and 90%. So, so this is a nice signal as well, but pretty toxic. And so we're still working on this dosing. And there's actually a new WEE1 now in clinical trials that Zentalis is making. And so we'll see what the clinical profile looks for that. We are pretty excited about WEE1, but just making it tolerable and safe for our patients has been really the Achilles heel for this sort of a strategy. Now, just ending with sort of what's just bread and butter platinum resistant, just so you know, it's not all just about post-PARP, although that's kind of where the highest unmet need is. Just to remind you what the standard of care is when you're platinum resistant, it's Aurelia, right? Bevacizumab and chemo, which is not a new study. You all know this. Paclitaxel, topotecan, which doesn't work, or Doxil with Bev works better than chemotherapy alone. And here's all the individual cohorts with remarkable improvements in the progression-free survival if you had Bev. And this was all in a Bev naive population, which probably doesn't exist in this population anymore, but we still use this as the benchmark, and it is the FDA standard of care. And here's kind of just what was from the JCO paper for PFS and OS, 3.4 versus 6.7 months when you add Bev. So this is the standard of care. Here's the historic in 1 to 2 priors. Here's kind of historical activity. This is from the Hanker paper. We all reference this. Response rates in first platinum sensitive, platinum resistant recurrence, second, third, fourth. The response rates just plummet. You know, second recurrence, you're 8%, 3%. So you might say, well, that's not real. You know, my patients do better than that. But here's contemporary data. These are really recent studies. I have a really at the bottom just for your reference. These are very recent studies looking at the control arms, which were monotherapy chemos with response rates of 4 to 13%. So patients really with platinum resistant disease just deserve a lot better than 4 to 13%. And so we just need to do better. These are all the studies that are ongoing. Well, actually not all of them, but a lot of them, just to sort of give you a sense of what's happening right now. Is a lot of really cool stuff going on. I'm going to just highlight 2 just to show you 2 very different strategies. One is the drug mirvetuximab, which in full disclosure, I'm very involved with. This is an antibody drug conjugate targeting folate receptor alpha. And Dave O'Malley presented this data with bevacizumab at ASCO this year in a kind of platinum sensitivity agnostic population. You know, if your patient was platinum resistant, they could come on. If they were platinum sensitive, but you didn't feel like platinum was a good option for them, which happens all the time, they could come on. Now, folate receptor alpha is a great target for ovary. It's been a good target for a long time. We've been trying to capitalize on it for years, but it's really overexpressed in most high-grade serous, and it's highly overexpressed in 40% of high-grade serous. And so when Dave did his study with Bev and mirvetuximab, in the high expressors, the response rate was 64%, which is really high. And then in those with platinum-resistant disease, it was 60%, and those with platinum-sensitive, it was 70% response rate. And the durations were very respectable. So we're excited about this potentially being in an NCCN listing expansion once we prove and get this approved through the MIRASOL trial. This is the registration trial for mirvetuximab versus investigator's choice chemotherapy, 1 to 3 priors, folate receptor alpha high. And so this is still enrolling. So if you have this open, thank you. Please keep screening. But we're going to know pretty quickly in the US ahead of this. This is SORIA, which is the accelerated approval attempt for mirvetuximab, going after with a response rate endpoint. This is completed accrual. We are expecting results anytime, Q4, which we are in. And there's a BLA anticipated in 2021. So assuming that this meets all our expectations, we may see an approval in the US for this, maybe late 2022. So something to keep your eye out for, because you'll start, precision medicine wise, you'll start testing for folate receptor alpha for that 40%. And then the last thing just to tell you about is another just completely different. This is the Gas6 axle signaling pathway. This has really been developed by Catherine Fu from Siteman in St. Louis, who's just incredible. This is her whole career's work. Basically, this axle receptor is very much overexpressed in a lot of cancers, but especially in ovarian cancer, and it's found in metastatic disease like in the omentum. This axle receptor will be way overexpressed. And then the Gas6 is the ligand, which just leads to all sorts of downstream effects that are good for the tumor, but bad for the patient. And you really can't block axle. It's a really complicated molecule to block, but you can suck up the ligand. So we have this drug called ABB 500 now. It's made by Aerovive. That basically is a Gas6 sponge. And we give it with, is this synergistic with a lot of things? I can't tell you about them all because it's not all published yet. Catherine's done amazing work. But what has been very recently published, you can look at it, it's in Gyn-Onc this month, is the work with paclitaxel, where there's synergy. Even in resistant, taxane-resistant tumors, you can resensitize them in the phase 1 work and in preclinical models with this ABB 500. So this is currently in a registration trial in 1 to 4 prior platinum-resistant tumors. It's called GG3059. Standard weekly paclitaxel versus weekly pac plus ABB 500. So we're very excited about this. Is a very new pathway. It's not PARP, it's not BEV, you know, it's not IO, it's something new that has a lot of beautiful preclinical work. So we're very excited about this. And if you have this open, thank you. If you're interested in it, email me. So in conclusion, I think there's just so much going on for our patients right now. That's great. I always have trials for patients, which is what I want to do. I always want to have options for people until we can cure and prevent their disease. But I think some of the key things coming are really looking at reversion mutations and incorporating that into how we select patients for trials and for treatments. Even in patients who are PARP naive, they already may have reversion mutations, and we need to know that. Just don't waste their time. Put them on something else. We're going to figure that out. The mechanistic understanding of PARP resistance is key. It is so much more complicated than we thought, and probably much more temporal. For the first time ever, we've always said we don't need to rebiopsy patients with ovary cancer. We can use our archival tissue for things because it's not a mutationally driven tumor, but they may acquire changes in the tumor that are important for the drugs we pick. That's a new thing for us. So we may be rebiopsying here, not yet, but it's coming. So the CCD1 amplification acquisition is a key example of that, but there are others. And again, I think just the quality of science, preclinical work, early clinical work that's going into what happens in the registration space is really outstanding. And I hope we'll just continue to move the field forward for our patients because they deserve it. This is the dog that's been bad this whole talk. She's real cute, but sorry about that. Luna, bad dog. Thank you. Right on time.
Perfect. Wow. Thank you so much, Dr. Moore. And that's okay. The dog is cute. Well, I wanted to open it up for questions right now. So if you have any questions for Dr. Moore, feel free to unmute yourselves. Feel free to use the chat box as well. We'll give you guys a couple of minutes in case there's anybody with a question. Oh, we have an applause from Thomas Killian. Dr. Moore, I am not seeing any questions.
That was a little bit of a fire hose. Information. I kept adding things today. I'm like, ooh, I'm gonna tell them about this.
No, but it all seemed like very great information. So I really do appreciate your time with us today and for sharing your expertise.
Yeah, I'm happy to. Thanks for having me.
Thank you.
All right. Have a good evening, everyone.
Thanks, Dr. Moore.
Bye.
Bye. Right, and then with that, we will move on to our next segment, where we definitely want to thank all of our exhibitors for their support and our corporate members. So we're going to take a 10-minute break so that everyone can visit the booths. The representatives are at each booth to speak with you live. So feel free to use the chat function, or some of them have a live link where you can speak with them on a video chat as well. And remember that we are competing for a $100 gift card. So if you can send me 5 of the unique competition codes that you find throughout the virtual exhibit, please feel free to email those before the end of the day, and that will put you in the running. And I'm typing in the exhibitor link so anyone can go and feel free to visit the booths. All right, we'll be back in 10 minutes, everyone. Well, all right, everyone. I hope that you had a chance to visit with our exhibitors. And the Nebraska Oncology Society is happy to announce that our member care packages were delivered in August. The box of goodies was made possible by the support that we received from our corporate members. So if you are a member and you did not receive a box, please let us know. And then I also wanted to make sure you knew of a couple of other updates. It is possible that we will change our November session from November 9th to November 2nd. I will be able to know and hopefully give you guys a complete update by the end of the week. And it was just a scheduling conflict. So it's just 1 week ahead. So I'm hoping that that's not going to cause any scheduling issues for our members and our exhibitors, but I will let you know as soon as possible. And then finally, I want to address our Nebraska Oncology Society events, as we have been very cautious throughout the year. You know, as the Delta surge continues, we'll continue to meet virtually unless we start to see it subside again. If you're a member, I do welcome any feedback you have regarding these virtual meetings. I know that we've been having them all year long. And so if there's any topic that you're interested in, or any opinions or feedback that you might have on the events, I'd love to hear it. And everyone, we've reached the end of our event. I wanted to thank you all for your participation and hope that you've enjoyed your time with us. I want to thank our speaker again, Dr. Kathleen Moore, for sharing her time and expertise with us. And definitely want to thank our corporate members for supporting today's program. I hope that you do enjoy the rest of the night, and we hope to see you at our next event, likely November 2nd, where the topic will be geriatric oncology. All right, have a great night, everyone.